We're on the lands of the Noongar people, but we work on, as the map shows, country all over Western Australia. It's an area the size of Western Europe. So from the Mirawan-Gadjurang people up in the Kimberley right down to the Noongar people in Esperance and all the lands in between. So the chair of our board is a Garriara elder and knowledge holder. So always like to acknowledge the fact that they, that's provided critical leadership for us and mentorship. These are our earbuses across the state. They're decorated with the artwork of local kids so that each region can recognise its own totems and each community can feel a sense of connection and ownership to the bus. The one in the middle at the top is actually a totally fake bus, because in the first couple of years we were the Earbus Foundation. So we had this sort of mock-up bus, so that's the fake one. All the others are real. And so today's presentation, we're going to try and give you a picture, I think, of how we think ear disease and hearing loss is really critical in this space, and why we are very focused on the work we do in terms of keeping kids out of the system, the justice system. So this is just how we've broken it down today, and we're going to try and cover the disease and how it impacts Aboriginal kids and how it interfaces with the justice system, and how what we do hopefully can serve as an upstream intervention that diverts kids away from that early engagement. And then we'll share a little bit of outputs and outcomes stuff with you. I'm going to do the first bit, Lara's going to do the second bit. And I suppose the core observation for us is that there are two different countries that we live in, right? Well, the one that we inhabit, and very successful, very rich country, and very prosperous one, arguably one of the most successful and richest countries in human history. But there's another one. The one that we live in has just about the best ear health on the planet. We've got a fantastic system for looking after people in that part of our country. Hearing Australia provides, free hearing aids. We've got newborn hearing screening in our hospitals. We've got a very, very good capture system. But the World Health Organization has a special categorisation of Aboriginal Australians as being amongst the worst affected people on the planet. So the worst countries in the world for ear disease are places like Tanzania, India, Solomon Islands, and then they've got this special category for Aboriginal Australians as having the worst ear disease on the planet. It is 10 times as frequent, and we think 10 times the burden of disease. So if you're Aboriginal and you're born in this country, then the first ear infection can start from as early as 2 weeks of age. But the killer stat is that these kids spend 32 months of the first 5 years of life with ear disease. For non-Aboriginal kids, that figure's 3 months. So this is where the 10 times burden of disease kicks in. The problem with ear disease, apart from being a nasty little, primarily bacterial infection, is that it creates a hearing loss, a totally avoidable hearing loss. And the hearing loss interferes with almost every aspect of early childhood development. But most critically, it interferes with the acquisition of speech and language. So these kids are entering school basically set up to fail. And the literacy impact, we learn to listen and speak long before we learn to read and write. You can't learn to read and write unless you basically learn to speak and listen. So it's the sort of can't hear, then you can't learn conundrum. And the higher prevalence rates in Aboriginal kids and Aboriginal communities are quite stark reading. The health survey that we took these figures from, nothing's changed much in the last 4 or 5 years, but 43% of First Nations people over 7 have got hearing loss in one or both ears. So it's almost half the population. 30% of the kids at critical school age between 7 and 14 got a hearing loss in one or both ears. So you've got, like this is higher in remote communities. It's between 40 and 50% in remote communities. So you've got sort of half the kids who are sitting in classrooms are struggling to hear what's going on. When you get to the impact of this on older Aboriginal Australians, almost 4 out of 5 have got a hearing loss. And we say that the oldest kid we've seen is 88 years old, because we're out there in communities dealing with the kids, and then the adults come in and go, "Oh, can you check my ears?" So this incredible stat is linked to middle ear disease in early childhood, and some of the stuff we've seen in older people's ears is really like, we saw a 17-year-old kid in Esperance who basically had no eardrums left. Just that they'd been rotted by the toxic gunk that had been sitting in his ear canal for forever. So it's a devastating condition, and it is way in excess of what the World Health Organization regards as a benchmark for a pandemic. So the World Health Organization's advice is that anything over 4% is a serious public health issue requiring immediate attention. And the rates that we're seeing are way in excess of this. So this is, in fact, I met the guy who wrote this benchmark, Andrew Smith, a couple of times from the London School of Tropical Medicine. And it's interesting that when we first went to the Pilbara, the rates of chronic ear disease were 15%. And in the Goldfields, it was 12%, and the Kimberley was 17%. These are world's worst figures, well and truly. So,
Lindsay has a question, Paul.
Sorry.
Lindsay has a question here. Is there any information on how severe the hearing loss is on average?
You're the audiologist.
The hearing loss ranges. So, what's technically a mild loss and categorized as a mild loss actually isn't mild at all. If someone has what we call a mild hearing loss, they're actually missing out on a lot of language spoken from a distance. If they have a moderate hearing loss, they're missing out on language one-on-one. And the vast majority of this hearing loss starts off in that mild category. For kids, it's devastating, and it progresses to moderate, and it fluctuates. So it can be mild some days, moderate other days. That's the nature of the beast.
And if you've ever had one of those hearing losses that comes with a cold, you'll know how disorienting it is and how debilitating it is to have your hearing disappear as a reliable sensory input. So this is kind of the cycle. Ear disease is very prevalent in Aboriginal communities because of the conditions in which they live. We'll talk a bit more about it in a moment, but it's a disease of poverty, essentially. So hence why Tanzania, India, there's other countries are high on the list. The poor living conditions cause the disease. It's primarily 3 bacteria, Haemophilus, Streptococcus, and Moraxella catarrhus that cause it. The early hearing loss, we mentioned the effect of that is that kids reach school not being able to hear. And the poor literacy and numeracy basically undermines any attempt at school achievement and school success. If you can't succeed at school, you can't learn, you can't earn. So the poor job prospects result in, and the cycle just goes round. And so our job is really to cut this off as early as we can. So this is just like the poverty causes the disease, and the disease perpetuates the poverty. So I'm not moving. There we go. The risk factors are essentially the social determinants, and when we go out into this other Australia that most Australians never see, this is what we are working with. Overcrowded, very substandard housing, not fit for purpose and not built in consultation with communities. breastfeeding has a very protective effect, and very often low birth weight babies, unwell mothers, and breastfeeding lapses quite quickly in lots of cases. There's the influence of passive smoking as an irritant on the epithelium and the ears is coming from multiple sources. These communities very often have reduced access to GPs, nurses, medications, and the availability of care. Hygiene practices are compromised often. There's communities that don't have hot running water, and things like airing mattresses and sheets and getting them washed and stuff. Nutrition is often compromised, and there's an overall very poor health infrastructure out there for people to rely on. And this is the reality. This is, there are more communities like this than there aren't that we see. And so when you live in this kind of milieu, if you like, then you are going to struggle to be well and to stay well. A colleague of mine, a guy I've got great respect for, Damien Howard's a psych in the Territory, and he gave evidence to a Senate inquiry that I also gave evidence to, and he said, this is actually the missing piece of the jigsaw. And he's right, that if we could fix this, then we would change the trajectory for these children, and we would change the poverty. You can't close the gap until you fix this, because of the 17 the number of targets in Close the Gap, in my view, is ridiculous, but I think the 17 or 18 targets, 2, 3, 4, 5, 6, 7, 8, 12, 14, are all linked to ears. You can't have a thriving childhood if you're not hearing. So this is why this is critical in the success of these children and their engagement as, fully enfranchised citizens. All of this is not going to improve until we can get these kids hearing, and we can get a generation of these kids through school. If we can't fix this, we're just going to lose more and more of these kids. So our sort of logic and assumption, and this is one slide I am going to read, is that the hearing loss from ear disease impacts speech and language development. It then presages critical literacy deficits and school failure. The school failure comes then with diminished self-esteem and low aspirations about what these kids can achieve. One of the things that we do at Earbus is continually talk to kids about raising their sights. You could be an ear doctor, you could test hearing, you could be a teacher, because we had a kid in the very early years who said to us when we asked, what are you going to do? He said, I'll probably go to juvie. So truancy and absenteeism, school attendance issues are rife, and kids who don't have language can't solve disputes with words, and they end up using their fists and physicality. So eventually what you get is disengagement from school and education pathways, and this is where that first engagement with the juvenile justice kicks in. So our aim as a program and as a foundation is to keep these kids in school able to listen and ergo able to learn. Because if we can't do that, we're just going to lose them. And so the Senate inquiry that I mentioned, he was utterly convinced that there's a link between early onset hearing impairment and engagement with the criminal justice system. The link is poor educational outcomes. The evidence from the National Aboriginal Justice Association showed that kids who completed school at year 9 or below were twice as likely to be charged with an offence, 3 more times likely to be imprisoned than kids who completed year 12. So it kind of backs up our assumption and what we see on the ground. And a colleague of mine, Anne Jacobs, gave evidence to that Senate committee that the early years study had shown that language skills at 6, 18 and 24 months strongly correlated with criminal charges in adolescents. So We don't know what the quantum of this is. There's been no large-scale study to show what the rates are in the custodial, what they're calling now the custodial estate, the prisons. So you can't shape a systemic response if you don't know the size of the problem. And we can't get a simple answer when we press on the justice system. Does the prison prevalence match the population prevalence? No one can answer that question. So the Department of Justice here identified 160 unique people in custody as having a hearing impairment. This is 0.6% of the people who entered custody during that time. I mean, it's a very bad joke. The prison system has no idea of how many people in it have got a hearing loss, and has got no systems really to deal with it. And we were encouraged here because the Inspector of Custodial Services commissioned an inquiry, and then basically identified the problem and said, well, the prison system's trying to fix it. Well, yeah, good luck with that one. There's also the issue of unsafe convictions, which is that when police interrogate Indigenous Australians, they should routinely expect a hearing test to be part of that, because people are engaging with the police and with the justice system who actually are not able to process what they're being asked or required to say. And the court system similarly, I mean, there are some horrendous stories of unsafe convictions. Damien Howard's website in the Territory is a good repository of this stuff, so I'm not going to labour it. But 15 years ago, when the inquiry reported, they said the case had been made to their satisfaction about the link with hearing impairment in the justice system, and that downstream solutions have to give way to upstream solutions. And it's no good trying to fix it afterwards. You've got to try and stop it happening in the first place. So that's why our design, which Lara's going to talk about, is very much focused on keeping these kids in school.
So from all of that, we have a program or programs that run around the state, and the role of our program is to provide services that are easily accessible to the community and accepted by the community. So Paul spoke a bit about our bus, which is decorated by local kids and their artwork. Immediately that bus is felt, the community feels like it belongs in their community. It's their bus, it's not our bus. And our outreach programs are always around collaboration. And it's such a funny word, that it's the buzzword. It has been for a long time. But what we find is true collaboration is actually not just ticking the box and saying we're collaborating. It's engaging and interacting at every level. And it's very, very difficult to do unless everybody is on the same page. So how big a focus is ear disease for Aboriginal medical services, schools, community health workers? This is a very, very tiny issue. AMSs are dealing with end-of-life situations and dialysis and all kinds of awful things. Focus not on ear health and not on those kids in those early years. Our other focus is around educating not just schools and teachers, but actually educating kids and families as we're going along. So our health messaging starts from the moment children come onto buses. We repeat, every single member of the team kind of repeats the mantra of whatever we're trying to get across. And you find at the end of a few months, the kids are starting to say that as well. It's just integrating into what they're doing. We measure everything, and I'll talk about the measurements in a moment. And our program looks different depending on which region and community you're in, because we tailor it to the community. So these are our goals. 4% is the benchmark for chronic conditions, and we try to push well below that as much as we can. One of our colleagues, who's an anthropologist from America, he came and observed our program in action, and his observation was, you lot have honourable relationships with people. How refreshing in health, was his comment, because it really is about people-to-people contact, adapting, collaborating. And then, we don't have brochures and posters that we pop up. That doesn't create awareness in community. Nobody's ever been cured by a brochure. So I'm quite anti-brochures at the moment. and then informed decision making. So have the stats that back it up. We're a one-stop shop. We drive in. All of our services happen on that bus. There's no onward referrals, go and find an audiologist somewhere. You just get pointed and you're next in line for the audiologist. There's no go and find yourself a GP and the GP's 3 hours away and you can't get in for 3 weeks anyway. If you need a GP, the GP's with us on the bus. We provide medication at the bus, so families don't have to go find a pharmacy and negotiate whether they pay the gap for their pharmacy cost or not. The program was designed by Aboriginal people and for Aboriginal communities. So it is very much a grassroots type program. We are in each community monthly, so regularly. You'll find that a lot of our kids are very transient. So if we're there in February and we see some children, we're there in March, many of those children won't actually be in community. But we're back in April and we'll pick them up again. And we also track all of our children. So if you're not in community in February, we find out where you are and we go to that community and track you down. So we always say you can run, but you can't hide. Earbus will find you for your services. And then we operate where kids go. So we're not sitting in a clinic waiting for people to come to us. We take the clinic to the community and we'll see anyone. So schools, playgroups, daycares, under trees, near the local police station where all the non-attending kids are hanging out. We'll go wherever we need to. And the program brings together so Paul's educational background, and we work in those settings. We've got allied health, my audiology background, so it is about the hearing, and then we've got the health focus as well. So bringing all three of those together in one spot. Always include this slide because it's not numbers. We're not talking about numbers here. We're talking about people and children. And these are kids that you get to know because you see them 12 times a year and you spend time with them. And each of these little people were on a pathway potentially into juvenile justice. And that's what we're trying to stop, that pathway for this individual. These are the kids across all of our communities. And you can see there's a picture there of one of the kids looking in one of our screeners' ears. The kids get to touch and play with everything on our buses. There's no off limits. The otoscopes, the equipment, they get to see how it works. They work out how to turn it on. That's the aspiring to be something bigger than what you currently are. So I'll just talk a little bit about our outputs and outcomes, and then we'll finish up in a bit. We're across WA, so we take on about just under 90 trips a year across the state. We work in the school terms, so we can have 2 or 3 trips going in any one time, and we visit every month. The community's identified it's that consistency of service and the consistency of personnel of what they want. All of our services are FIFO. If you work regionally at all, it's very difficult to recruit people regionally. It's very difficult to keep people regionally in WA because you're competing with the mining dollar in terms of employment. So as soon as you've trained anybody up, off they go and work on a mine site somewhere. So yes, FIFO is not as ugly a word as what people tend to think. And this is what we've done for the last 11 years. We've seen just under 16,000 children across the state. And 144,000 sounds like a big number. That's how many times children have received a service of some description from us. Nearly 40,000 hearing tests. Identifying hearing loss and taking action on hearing loss, and nearly 26,000 GP consults. So these are kids who otherwise wouldn't engage with primary healthcare. And when we see the kids for ears, our GP doesn't just look at the ears, they look at the whole child. So anything that child's got, anything that child identifies, that's what gets treated. And then some children go through to surgery, so ENT. If we treat from a primary healthcare perspective and we can't improve the hearing any further, then children go through and have simple surgery. And here's our outcomes. And this is just a graph just to show that. So in our first year of operation, everybody was new, 100%. As we grow and expand, the percentage of new kids in the program goes up. But on average, it's about 30% of kids move through our programs as new children every year. And The rest of the children are very transient. Our data drives everything. And if you're looking at this graph, if you look at 2016, for example, nearly 36% of children had otitis media across all of our programs. And we managed to push that down to about 13 or just under 13% this year. But in some communities, that was 100%. So, it's a lot of kids that we're looking at here. And this is just on average, just to give you a flavour. Chronic suppurative otitis media, so that's a torn eardrum with pussy discharging ears. The rates in some communities, 30-40%, but on average across all of our programs has gone down from 10% down to 3.1% across all of our programs.
Which is under the World Health Organization 4% benchmark.
Yeah. This downward trajectory, we look at each program and you can pretty much see it. If it started at 40%, it's the same downward trajectory. It takes about 18 months to get that chronic running ears across a community to stop. And then our hearing loss kind of hovers around the 16% mark. It's been as high as 40% some of the times. This is with treatment. So this is our worst case scenario. Even with treatment, 25% of some kids had hearing loss, and that might be because they're waiting on surgery. We can't do anything. We can get them hearing, but they've technically still got a hearing loss while they wait on surgery. So we measure everything. I mean, that's the point of just showing us lines. So that's a little bit about us. I will stop sharing now.
Thank you so much, Paul and Lara. That's compelling, and as Lindsay said, it's pretty grim, but also it sounds like it's an incredible opportunity because it's one of those instances where there's a particular target that you can target and make a difference in that can have quite profound and diffuse benefits. So, I mean, huge congratulations on what you've achieved with Earbus. It's quite incredible to see what you've done and how much work must have gone into it. Look, I might turn over to others. I'm sure I've got a few things I could ask you, but I might turn over to others who have a comment or a question they'd like. Please just feel free to unmute yourself. James.
I was just going to, thanks for the presentation. I was going to, you did touch on the fitness to stand trial issue, and I know, fitness to stand trials dealt with a bit differently in Western Australia compared to the jurisdiction I work in, but I just wonder if you might comment on the extent to which hearing impairment is affecting people's ability to take part in court processes and how much that might be under-recognised as a cause of people not adequately being able to defend themselves in court.
James, I think when I was preparing this and I went back and looked at some of the evidence for the Senate inquiry, some of the instances that were highlighted were really quite shocking. And so that kind of heightened awareness, but the system still, I don't think, has responded adequately. There has been a glimmer of hope here in the Children's Court because after a lot of lobbying, and there was a very proactive president of the Children's Court, Dennis Reynolds, who basically wouldn't hear the cases unless he had a full range of assessments available to him. So in the past 18 months, they have started to do assessments prior to the kids appearing in court, which has been a step forward. But it's a very difficult system to make work, and we've been testing kids at one of the secure centres in the Perth Hills where they get remanded to, and so there's still no systematic response. And that we've been lobbying locally. In fact, 2 weeks ago, I was meeting a member of the state opposition to talk about questions being asked at estimates and so on. So I think if we could actually document the way that Damien Howard's done in the Territory, I think we'd probably find a similar profile here of unsafe convictions and people just nodding in court and saying yes when they should actually be saying no. So.
And if you look at the stats that we're seeing in kids, and these are not kids who are in justice at all, but the stats that we're seeing in kids who've been untreated for hearing loss, there's no reason to expect anybody who's in the justice system to have statistics any different to what we're seeing in kids who are out there in community.
Back in 2010, we got into Bandy Up Prison. We just snuck under their guard somehow, and we tested half of the muster. It was 300 at the time, and we tested 150 of the women, most of whom were Aboriginal, and 46% of them had a existing or long-standing hearing issue, and there's nothing to suggest that that's changed in the interim. Lindsay?
Yeah, thanks, Laura and Paul. That was really interesting in an area I really didn't know anything about, and I have a lot of questions, and I'm at risk of rambling and just saying a bunch of things, but I guess it just seems like there's such an opportunity to collaborate with justice and filling the evidence gap, like you were saying. Like, there's really no information on how many young people in the justice system experience ear health issues. That's obviously a problem that we need to address. And we, like you said, it's unknown if that would be higher than in the community. And I'm just wondering, and I think you kind of just alluded to it there with James's question, just around, have you done any formal engagements or thought about how you could potentially collaborate with Justice or Banksia Hill? I guess you're kind of more potentially focused in the regional areas, but obviously a lot of kids from country out in the regional areas end up in Banksia and are displaced from community, and that would just be such a challenge for follow-up as well.
They reached out to us, didn't they?
They did. We've been trying to engage with Justice for 12 years.
Since 2010, when we did the Bandy Up work, we've had, conversations on and off. We think we're making headway. We had one that was auspiced by John Quigley, the Attorney General. It's one of the deep frustrations we feel is that they kind of view us as the enemy, and we're not the enemy, But I'll give you just a little example. At Bandy Up, they got crucified in the media because they had a cappuccino machine, and they were trying to teach the women barista skills so that upon release they could have a job. But that got distorted in the media to be a convicts drinking cappuccinos at our expense story, a real low narrative. Mm-hmm. And so they got very badly burnt by stuff, and they were almost gun shy in justice about. And so they were kind of looking on us as though we were trying to paint a bad news story about ear disease in prisons. In actual fact, we were saying, look, you've done something, this is a good news story, but they didn't know how to craft it. And so they're very badly affected by the narrative as well. And when I met with that politician 2 weeks ago, he was complaining about how, all the government here was playing to a tough on crime narrative. And I said, well, come on, you've contributed to that narrative as well. You can't blame the other side of politics. You're both as guilty as each other of playing this card, and it does. It affects the way this plays out. So we look for any chink of light we can find to get into the system, but they keep us very much at arm's length.
I would imagine too, like a lot of healthcare providers in custody in Banksia Hill and other facilities would really love this program, because they often complain about not having enough resources to do what they need to do and meet the needs of the young people in their care. And here you guys are with an amazing program that is so accessible if it's just allowed.
And Damien's comment there about Parramatta Jail doing bar courses with water and still getting pilloried for it. Look, the sad thing for us is that, we see kids turn up in the detention system who we know or we've seen, and you know, so I remember one kid very much from Leonora, who I think we got there 12 months too late for him, and I know he's going to turn up in the newspaper at some stage, and I'm going to see the name, you know, and so it becomes kind of very personal, and you're on a mission to keep these kids out of the system, because you can see the pathway looming, you know, and something as simple as just keeping them in school, and keeping them able to participate and to learn and to feel like they're succeeding is, sorry, I'm on my soapbox, but
Sarah and I are working another project, and we did an interview yesterday with a youth criminal justice lawyer from Aboriginal Legal Service of Western Australia. But she was saying a very similar thing around empowerment and just the importance of having encouragement and supporting young people to see that they can do something different in life and you know, have that opportunity and the potential to do that. So that is a really important point that I think you just made.
Yeah. Stuart.
Yeah, look, it's this seems like a very poignant instance of the broader issues with trying to inject equitable evidence-based practice into criminal justice settings. I don't think we've got anybody from justice on the webinar today, but if there is, please feel free to chip in. But Paul, you made that comment. I think it was kind of a bit off the cuff. You said downstream solutions must give way to upstream solutions. And, you know, you've clearly made an absolutely compelling case that prevention is much better than cure, you know, and sometimes cure isn't possible. So the upstream prevention and early treatment of ear disease is much better than waiting for young people to end up in the youth justice system. But I think you've also made the point that it doesn't need to be an either or, and we most certainly should be doing routine screening. I mean, I think given the prevalence estimates you had in the general community, and that hearing loss is associated with criminal justice involvement, you would reasonably expect the prevalence to be at least that high in youth detention and not 0.6%. And the challenges you face are an instance of, you know, what we've called epistemophobia, or the pathological fear of knowledge. And I think, you know, this is a perfect instance of it. And I suspect that one reason for that is that once you know the problem's there and that it's highly prevalent, you need to invest appropriately to respond to it. And certainly in the WA context, it's my understanding, obviously I can't speak on behalf of government, but that's been a long-standing, privately acknowledged, publicly denied challenge, having adequate funding for care, healthcare, and other forms of care in custodial settings. You may have seen in the last couple of days the report of the coroner's report following the death of Cleveland Dodd was released, and it sounds like there is a move towards finally transitioning healthcare and youth detention, at least, away from corrections to health. And I wonder if that might provide some opportunities. So, you know, instead of talking to the brick wall of justice on these issues, talk to a Department of Health that actually has a mandate to care about health. That may be an observation, maybe a question, please. I'd love to hear your reflections.
I'm just going to say the health department, very good at hospitals, surgery, all kinds of things, engaging with Aboriginal communities in community. In some instances, person dependent, yes. In other instances, not so great. You know, I look at our service and go, it's the people that make the difference. And I do not envy the health department. I'm trying to staff across the whole of WA clinics and having people there that are culturally appropriate and engaged with communities, but it's a big ask.
And the system has a long track record of distrust with Aboriginal communities. You know, we went to a regional centre in the north, and our consent form asks, can we share this information with, you know, the local health community? And the answer was a flat no, right across the community. And we had two people who said yes. But the vast majority was like, no, you cannot share this. And so we tried to drill down. And of course, the fear was that it would be used as shaming of parents to say, your kids are all got terrible ears, you know, and then it goes to kids being taken away. So there's a long, long history of distrust between the government system and Aboriginal communities. So our work has primarily been about building trust, and there are no shortcuts to building trust, right? You just have to go to the community, you have to sit down, you have to listen, you have to learn, you have to be humble, you have to take on board what the community knows and what they want, and you know, so there are just no shortcuts. And during COVID, we had 180 regional trips scheduled, and we delivered all of them bar 3. Okay. Now, not all of them were doing clinical work. Sometimes it was just taking tissues and sanitizer and soap out to communities. We had a community ring us to say, are you guys still coming? Because your doctor, we've got 5 sick kids. Nobody else is coming. We've had communities keep roads open during traditional law for us. And so our work really has been about building trust. And so we keep the same teams visiting the same communities wherever we can. And the message from us is we're here for you. We're here for what you need. And we're here as a resource for your community. Use us as you see best. And government simply can't do that. It just can't. So.
Sarah's got a question.
Hi, thanks for an amazing presentation. I love this program so much. I'm kind of wondering, like, how can we help? What do you think or how could we maybe work together to provide some evidence and inform priorities for custodial settings, particularly youth detention? And then second question is, do you know if there is routine screening on admission to places, say Banksia Hill, for example, and if not, or maybe what you think the best screening tool would be if we were to implement that?
I don't know if they're currently doing screening. I think you're thinking of what I'm thinking of.
Well, the answer when you ask is, oh yes, everybody's like has a screening on. Look, I worked at Fremantle Prison when it was a maximum security prison, so I kind of know the jargon a bit and how these things work from inside. So at reception, when prisoners come in, they say they have a routine screening. But it's not a clinical screening. It's really often just, do you have any problems with your ears? And then the answer is, well, within 3 months of admission to prison, to reception, they will have a full GP assessment. This is Western Australia. But of course, a lot of people are on short custodial sentences, so they're not there for 3 months. So when the Office of the Office of the Inspector of Custodial Services did this report, it looks on the surface like, oh yeah, they've got all these systems in place, but in actual fact, when you start to drill down into it, a lot of it just doesn't happen. And they can't aggregate data, so they can't tell you how many prisoners have. It's all individual data. So when you start to drill down into it, it all kind of just falls to pieces at the touch, I think. And if you asked me, do they have a handle on ear disease and hearing loss in prisoners in the custodial estate, my answer would be absolutely not. But it's like, bureaucrats are very, very good at giving you answers to make you go away. So it's finding the next question. It's the drill down that you get at estimates. And so I have put a whole series of drill down questions and basically given them to the opposition, because the minister has basically just fobbed us off. and said, yeah, no, everything's fine, nothing to see here. It's all under control. All our systems are, so you could kind of need to keep going back and asking the next level of questions and then the next level of questions. But I don't know why it's so hard, because really all we want is some information about so we can come up with a solution,
I was also just going to say, you have to remember that this is a hidden disease. So I could ask you, who here has got a hearing loss, unless you've had a test. If you've had a hearing loss from when you were 2 weeks of age, you're habituated to it. You think this is how everybody hears. And we can see it in kids who, they come in and they're 12 and they've got a massive hearing loss, and you ask them, how are your ears? And they tell you that they're fine. Like, they're looking at you and they say they're fine, and you test them and they've got this massive hearing loss, and you think, how can you, this is not fine. They don't know the difference. So,
and my contention, having seen Aboriginal prisoners in the system up close, is that when they come into reception to prison, they do not want to be seen as disruptive. They want to be seen as compliant. So if you are asking this, then you have to do it in a culturally safe and sensitive way. If you're just doing it as a white fella question, you're probably not going to get accurate data back.
Mm. Thank you.
This is a very complex space. I'm not telling you anything you don't know, but working in Aboriginal Australia is extremely complex and nuanced, and it takes a long time to understand how it works. And the prison system, I don't think has a handle on it properly. I really don't.
I think Shorts NZ, maybe our last question for the day.
Hey, thanks for that, Stuart. Hey, look, that was a really great presentation. Really, really enjoyed it. It made me feel very humble looking at that frontline intervention that you guys do. My question to you is, how do you cope, or how do you manage the kids' communication skills going forward? So you go in, you sort out, it's otitis media, and presumably in some of your testing, you'll find out that some of those kids have got nerve deafness as opposed to otitis media, for example. I mean, when you see the kids, are they, particularly for the first time, how are they communicating? How do you communicate with them? Do you teach them ESL? I mean, obviously you don't teach them ESL, but how do you manage their ongoing communication challenges?
Now, a lot of these children, we're working in a third or a fourth or a fifth language. So I just say that up front in terms of communication is some of these kids have never spoken English till they come to school, and you've got to be mindful of that. Always we're looking to reduce the impacts of the hearing loss in the first instance and looking at all the medical interventions that there are. Yes, we do find kids who've got a sensory neural or permanent hearing loss, and they get referred through the government system because the government fit hearing aids to those children. And we do the ongoing maintenance because we're in the communities regularly for kids. I'm thinking of, for an example, we were in one community and we saw a 5-year-old who had otitis media, and when we resolved the otitis media issue, she still had a sensory neural permanent hearing loss and had been missed. Spoke to her father, who said her hearing is fine. Asked the teachers, who said her hearing was fine. What was fine was that she was a bright little cookie and she knew how to read all the social cues and did all the things that she was supposed to do, and she got hearing aids at the age of 5.5 for the first time. Aboriginal communities are fantastic because this notion of disability, and this is my interpretation as a non-Aboriginal person, disability doesn't exist. Conceptually, it's difference.
Yeah.
So, in one community we go to, there is a profoundly deaf lady who's there, and she can't speak. She's been profoundly deaf since birth, and she absolutely communicates better than I do with the entire community because they just adapt to her. And she grunts and points and does everything, and the kids all do things around her. She has no communication issue whatsoever. Is it easy for her? No, but the community just adapts around her, and that's fantastic to see.
So for a lot of the kids who have a middle ear disease induced hearing loss, we can bypass that by using bone conductor assistive devices. And so we're actually trialling a product from the UK that we've found at the moment, which is quite transformative. If we can get the kids' grommets into the ear canal, that's transformative as well. We've done surgery on a child on Tuesday and had the school ring us up on Friday saying, "What have you done to this kid?"
That's amazing, yeah.
So it's every individual child. That's the point of the slide that said not a number, because we case manage every single child individually to try and get them hearing as quickly as we can and get them back on the air. So it's that sort of hands-on, individualised case management that's, I think, the strength of our program.
And I know we're running short on time, but I will just also mention, once the hearing loss is sorted, these kids are often left with a permanent disability, and that's the auditory processing disability. They've missed out in those first critical years for brain development. They've missed out on all the neural development that needed to take place to integrate hearing and make sense with what you hear and be able to hear in noise and be able to localize sound. They lose that ability and they never get it back. So, spoken to kids who say they can hear, but they just don't understand what's required of them. And it all comes through rehabilitation is needed, and it'll be a lifelong thing for them.
So while their brain can hear, their brain can't process the information it's hearing.
Yeah.
It's an auditory processing issue that is lifelong.
I think, Lindsay, if it's a quick one, please go.
Yeah, really quick. I'm just wondering if there's anything that you're able to do around that or facilitate access. It's obviously another massive challenge, but that seems...
It is. Look, in a school context, there are things that you can implement, but if we had the funding, we would run programs for all the kids. But yeah, very, very difficult to rehab that with limited funding and no government acknowledgement that the issue even exists.
And low levels of teacher awareness and skill at remediating it. It's a speech pathologist supported and supervised intervention that you need there. And we are actually trying to develop wraparound foundational targeted services at the moment to be able to support the schools to do that. But again, it comes down to funding and resources. So